If you're getting ready for the NG-NCLEX, you know that cardiac questions are all about safety, right? Well, today we're going to absolutely master one of the most critical procedures you'll face, cardioversion. And trust me, getting this right isn't just about passing an exam. It's about knowing how to save a life. So let's dive right in.
Okay, let's start with the single most important rule. If you walk away with one thing from this whole review, please let it be this mantra: fast heart rate plus a pulse plus an unstable patient equals cardioversion. This little formula is your decision-making key. It will unlock the correct answer for pretty much any cardioversion question the NCLEX throws at you.
So here's our game plan. First, we'll get the big picture. Then we'll tackle the #1 trap that students fall into, sync versus unsync. After that, we'll dig into how to spot an unstable patient, walk through the procedure step by step, cover what to do after the shock, and then wrap it all up with a rapid review to make sure it all sticks for exam day.
All right, so let's start at the beginning. Why does the NCLEX test this so heavily? It's simple, because getting it wrong has immediate, life-threatening consequences. Cardioversion is all about hitting the reset button on the heart to restore a safe rhythm, and your job as the nurse is to make sure that reset is done safely. This definition right here is packed with NCLEX keywords. Let's pull them apart. First, it's planned, which tells you this isn't usually a chaotic code blue situation. Second, and this is the most critical part, it's synchronized. The machine is smart. It times the shock to land perfectly on the R wave. And third, and this is non-negotiable, the patient must have a pulse. No pulse, no cardioversion, period.
And that brings us to the #1 trap the NCLEX sets for nursing students. Seriously, understanding the difference between a synchronized shock and an unsynchronized one is everything. It is the absolute core safety principle of this entire procedure. Get this, and you're golden.
This table just lays it all out so perfectly. Look at that first row, timing. Cardioversion is synced, defibrillation is not. Now, look at the second row, used for. This is the fork in the road. Cardioversion is for tachycardia, with a pulse. Defibrillation is for cardiac arrest, no pulse. Everything else flows from that one single question you have to ask yourself: does my patient have a pulse? So why does this synchronization thing matter so much? Why are we so obsessed with it? Because if you deliver an unsynchronized shock to a patient who has a pulse, you run the risk of delivering that electricity at the worst possible time, right on the T wave. And that isn't just an incorrect answer on an exam, it's a catastrophic, life-ending clinical error.
This is called the R on T phenomenon. You see, the T wave is when the heart's ventricles are repolarizing, kind of resetting. It's a very vulnerable electrical moment. A shock right then and there can send the heart into the most chaotic, lethal rhythm there is, VFib. So to make sure you never forget this, burn this into your brain. Sync on or VF is born. It's your most important safety check. Okay, so we've established we need to sync for a patient with a pulse. But which patient with a pulse needs cardioversion right now? This is where your clinical judgment, your nursing brain really has to kick in. You have to learn to spot the cues that scream, this patient is unstable and we need to act now.
And I'm going to make it super simple for you. It's a two-step thought process. Every single time you see a fast heart rhythm in an NCLEX question, first you ask, is there a pulse? If the answer is yes, you immediately go to step 2. Is this patient showing any signs of being unstable? If the answer is yes again, boom, your answer is synchronized cardioversion.
And these are your red flags. These are the buzzwords the NCLEX will plant in the question: hypotension, chest pain, crackles in the lungs, new confusion, cool and clammy skin. And why are these so bad? Because they all point to one thing: poor cardiac output. The heart is beating so fast it can't fill up with blood, so it's not pumping enough out to the brain, the lungs, or anywhere else. That's the emergency.
Okay, the decision's been made. We're going to cardiovert. Now, how do we actually do it safely? The NCLEX expects you to know the correct sequence of events. Think of it like a pilot's safety checklist before takeoff. Every step is crucial.
First things first, let's talk about patient comfort and safety. Getting cardioverted is painful, so if your patient is awake, they absolutely need to be sedated. But here comes the NCLEX priority question. If that patient is crashing, I mean their blood pressure is tanking fast, you do not delay a life-saving shock to wait for sedation meds to kick in. In that moment, it's life over comfort.
So let's walk through the flow. 1, confirm you've got the right rhythm and a pulse. 2, and this is the most important button you will ever press, hit that sync button on the machine. You have to physically see the little markers show up on top of the R waves. Then, apply the pads, sedate if there's time, deliver the shock, and immediately reassess. Did it work? What's the new rhythm? What do the vitals do?
The shock's been delivered. Phew, right? Not so fast. Your job as the nurse is far from over. In fact, post-procedure monitoring is a massive focus for the NCLEX, because this is when complications love to show up. Your vigilance here is everything. So here's what you're watching for. Keep them on the monitor. Did they slip back into that bad rhythm? Are their vitals staying stable? And this is huge, especially for patients with AFib or A-flutter. You are now on high alert for signs of a stroke. Why? Because when you shocked that heart back into a normal rhythm, that organized contraction could have dislodged a tiny clot that was hiding in the atrium.
And this brings us to a major NCLEX logic point. If a patient with AFib is stable, the priority is to get them on blood thinners for a few weeks before you do an elective cardioversion. That prevents a stroke. But if that same patient is unstable, hypotensive, having chest pain, you don't wait. The instability is the immediate threat. You shock now and you worry about anticoagulation after they're stable.
All right, let's lock all this in. We're shifting gears into a final rapid-fire review. This is the exam gold, the key takeaways you absolutely have to carry with you into that testing center.
You have to be ready to spot these wrong answers. The NCLEX will dangle them in front of you. If a patient's in VFib, they're dead. They need defibrillation, not cardioversion. If they have AFib with a pulse, you sync. You never defibrillate them. Forgetting to hit sync or not sedating a conscious patient, those are critical safety errors. Know what's wrong so you can confidently pick what's right.
Think of this as your final drill. Let's make it automatic. Look at the pattern. Any fast rhythm plus a sign of instability, low BP, chest pain, confusion. The answer is cardioversion. No pulse at all, like VFib or pulseless VTAC. The answer is defibrillation. It really is that straightforward.
Okay, let's put it all together with a classic NCLEX-style scenario. A patient comes in with atrial flutter, their heart rate is 160, their blood pressure is 78/40, and they're pale and sweaty. You've just recognized the cues.
So based on what you see, what is your priority? What's the very first thing that you, as the nurse, need to do? Think back to our two-step rule.
The priority action is to prepare for synchronized cardioversion. Let's break down the why. Step 1. Do they have a pulse? Yes. Step 2. Are they unstable? Absolutely. That blood pressure is dangerously low. Therefore, they need an immediate electrical fix. Giving them a beta blocker is way too slow, and anticoagulation can wait. The number one priority is to fix the rhythm that's causing the instability.
And that brings us to our final, most important takeaway. When you're in the exam, your heart is pounding, and you see a question about a fast heart rate, the very first thing your brain should do is check for a pulse. If a pulse is present, you think sync. That simple connection is the key to patient safety and to acing these critical questions on the NCLEX. You've got this.